Welcome everyone again to the Canadian Breast Cancer Network's Questions and Experts session today. I'm Jen Gordon, I'm the Director of Operations with the Canadian Breast Cancer Network, and I'm really thrilled to welcome you this evening to our session. Before we begin, I just wanted to quickly cover a couple housekeeping items. So the session will be recorded today, and you will be able to actually find the recording on our website. I will put the link in the chat. That will be up probably later this week. And also all of the recordings of our previous webinars and Q&A sessions are available there as well. So I'll put that link directly to the page on our website that you can find those. The session is fully dedicated today to taking your questions. So we have had some questions submitted in advance, but I would encourage you to use the Q&A button or tab, probably on the bottom of your screen or maybe along the right-hand side. If you can't find that, you're welcome to use the chat function as well to submit your questions throughout the session today. I would like to extend our sincere appreciation to all of our sponsors who've made this session possible. So our gold level sponsor, Beatrice, our silver sponsors, Novartis and Merck, and our bronze sponsors, AstraZeneca and Pfizer Oncology. And on that note, I would like to turn it over to the host for our session today, Kathy Amandalea. Kathy is the chair of the board of the Canadian Breast Cancer Network and has personally experienced a breast cancer diagnosis, so knows firsthand how important it is for everyone to have the opportunity to ask experts like Dr. Seeley their questions. So Kathy, over to you.
Thank you, Jen. And thank you everyone for joining us tonight. I'm so pleased to welcome back radiologist Dr. Jean Seeley, who joined us earlier this year in our webinar about post-breast cancer surveillance. If you missed that session, I would encourage you to visit our website and view the recording, as Dr. Seeley shared a tremendous amount of information about surveillance post-diagnosis. Jen will post a link in the chat for those who may be interested. And for those of you who missed the previous session, let me provide a quick bio of Dr. Seeley. Dr. Seeley is a leading breast radiologist at the Ottawa Hospital. She is a professor of medicine in the Department of Radiology at the University of Ottawa. She is also head of the breast imaging section at the Ottawa Hospital and is the regional breast imaging lead for the Ontario Breast Screening Program in the Champlain region. She is the president of the Canadian Society of Breast Imaging and also serves on the editorial board of the Canadian Association of Radiology Journal. Dr. Seeley, welcome back, and thank you so much for joining us this evening.
Thank you so much. It's a pleasure to be here. I think speaking and collaborating with our patients is the best way for us to improve. And I think it's a great opportunity to share knowledge to empower everyone on how to advocate for themselves optimally. So I'm very happy to be here. Thank you.
Great. I'm sure we're going to have a very amazing evening. So to get things started, we'll begin with a couple of questions that were submitted in advance and then move on to some live questions as they're coming in. So actually, before we get to our first question, maybe you could explain the difference between breast cancer screening and surveillance, just so participants can understand how the two differ.
Yeah, it's a great question. So we typically use the term screening when we're looking at diagnosis of breast cancer in women who have no symptoms. And so when we look at screening overall, we're looking at women who typically don't have a personal history of breast cancer. And we're just women at average risk with a 12% lifetime risk of getting breast cancer, 1 in 8. And we're screening women to see if we can detect cancers early before they become symptomatic. Surveillance, we use that term, it's similar in a way, equivalent to the term screening, but we're using it specifically in the context of women who have a personal history of breast cancer. So if we say surveillance, it means that we know that the woman we're doing the imaging on has a previous personal history of breast cancer, and we're surveilling, we're screening, in fact, to see if there's either a new breast cancer diagnosis or a recurrent breast cancer diagnosis in the breast that had the cancer or the other breast, if there's breast tissue remaining.
Yeah, so the question still remains that partly is the surveillance and the screening, is the imaging done differently?
Oh,
Do you not look in the same way when you're looking?
absolutely. Yeah. I like words. They're very important. So words can convey things very quickly. And so that's why if I say surveillance to an oncologist or a radiologist, they know, okay, I'm dealing with somebody who is being screened, but they have a personal history of breast cancer. So you're absolutely right. If I have a previous history of breast cancer and I'm getting a surveillance mammogram, it means I have no symptoms of breast cancer, and I get the same mammogram as one of you who doesn't have a personal history of breast cancer. So what that mammogram would be is 2 views of the breast, where we squish the breast craniocaudally, and on the side, mediolaterally, they're exactly the same. So it's the same test, but it indicates the history when we use the term surveillance. Does that make sense?
It makes sense. So I guess it's mainly for the radiologist to look at it in a different way, for you to know that this patient has had a previous history.
Exactly. That's
Okay.
right.
All right.
The only difference.
Yeah, that's very clear. But you could understand how somebody could say, screening versus surveillance. So we just wanted to make sure that technology is used in the same way to image the breasts. Okay.
Absolutely.
Yeah.
See, we've already achieved a lot in this short.
We did. Okay, so I'm going to get to the questions that were submitted. And my first question is, when is tomosynthesis in conjunction with mammogram, ultrasound, and MRI appropriate for surveillance after breast cancer? And also, maybe you could explain that tomosynthesis is for anyone who is wondering. You could explain what it is for anyone who is wondering.
That's right. So I realized when I agreed to this, I wouldn't be able to show images. And, it's very difficult as a radiologist to talk without images, but I'll do my best. So tomosynthesis is a mammogram, but it's like super mammogram. So it uses, so instead of taking a picture, one picture, say, with the breast compressed like this, the breast is compressed like this. And instead of taking a picture like straight through, it takes a series of images through the breast at different angles. Okay, so it does a sweep of images. Now, all of those X-rays that it takes are so low dose of radiation that the sum of those images is equal to a regular 2D mammogram. And the tomosynthesis, because it takes these angles, different X-rays at different angles, what that does is it gives us the opportunity to almost get a 3D image of the breast. Now, that's very good because it reduces the overlapping tissue sometimes that we get with a 2D mammogram, where when you have an overlap of things, it can make things look like a mass or a lump on the mammogram, but the 3D image makes it very clear that it's not a mass. So tomosynthesis is what we call the better mammogram. It's helpful because it reduces the overlapping tissue issues with a mammogram, and it allows us to diagnose more cancers. So we know that in a large studies that if we use tomosynthesis, we detect 2 per 1,000 more cancers than a regular 2D mammogram. So again, to keep it simple, if you looked at a regular population of women who have no history of breast cancer, we would detect with a regular screening mammogram 5 per 1,000 cancers, okay? If we add the 3D tomosynthesis, we detect 2 more. Mm-hmm. So it helps us, it improves our accuracy for diagnosing cancers. So why wouldn't we use it for everybody, right? That would be the question.
Right.
So that question is being studied very actively. And we're involved. I'm a site investigator for the TMIS trial in Ottawa, and we have different sites all around. There are 90 different centers that are doing tomosynthesis for this study. So we're looking to see, does it actually help improve the survival and reduce the rate of advanced breast cancers by using tomosynthesis? You have to do that with large studies. So tomosynthesis, which is the same as 3D mammograms, okay, are being used in many, many places in North America and the US, in Canada, as well as in Europe. And we're using it in many centers in Ontario and across Canada, but it's not the standard yet. And so it's gradually getting there. So we don't have and again, we try to do everything based on evidence, but we don't have tons of evidence to say that it's going to be better, but we're pretty sure it is, especially for women with previous history of breast cancer.
Right. So what would you say to somebody listening and knowing that they're going to a center where they don't have this sort of imaging? Should they be concerned or find somewhere where they would offer this?
No, because we have really good evidence that 2D mammograms work. Okay. The one thing I will say, and I think maybe somebody mentioned in the chat, is that women who have the most dense or the densest breasts, who have dense breast tissue, the tomosynthesis mammogram works, but it's still not perfect. We still miss cancers in women who have dense breasts, whether they've had a previous personal history of breast cancer or not. It's estimated that there are 15 per 1,000 cancers in the average population of women, 40 to 74 years. And mammograms finds 5. So that means probably we're missing 10. And that's often in women with dense breasts. So that's the problem. Mammograms are not perfect. And even adding on this 3D is great. It's better, but it's not finding all 15 of those cancers.
Great. That's great. That's clear. Okay. So the next question that was submitted asks, is the PET scan with the FES tracer available in Canada? And if so, how widespread is it used? I understand it is much more effective at imaging ER-positive cancers like invasive lobular carcinoma than the FDG tracer. Is that true?
I'm afraid I have no knowledge of this type of PET scanning. I believe I looked into this a few months ago, and I found that it was really not available in I think maybe one center. So I can't really answer that. We use PET for some staging of breast cancers, but it's really not the primary tool that we use to diagnose breast cancers or even metastatic cancers. But that's a question that I would really refer to somebody with more expertise in that area.
Okay. So I'm gonna turn it over to Jen because she has live questions coming in. Jen?
Yeah, so I have a couple follow-up questions. One's a quick one. So is tomosynthesis the same as a 3D mammogram then? Could you just clarify, can those be used interchangeably? Are they the same thing?
So the short answer is yes, but I will clarify this. Tomosynthesis is not a true 3D mammogram. So a true 3D image is one where we go around the whole body, okay? So we get that with MRI and we get that with a CAT scan. Tomosynthesis does an arc like this, okay? So it images a part. So we call it a pseudo 3D, okay? So yes, in the short, but it's not really 3D, okay?
I think that helps clarify that. And the other follow-up question was around this whole surveillance clock, if you will. So does the 1-year surveillance clock count from an original diagnosis when that patient's diagnosed, or from when they finish their chemo and radiation and whatever other treatments they're taking? When does that sort of start?
Yeah, so there's the consensus is that it starts from the time at the diagnosis. So if you were diagnosed in March 31st of 2022, you would be due for your annual surveillance mammogram in March 31st, 2023. And we try to accommodate that as much as we can with some leeway. So we usually will give 2 months flexibility. So we might have somebody who is, diagnosed March 31st, 2021, and then they come back and they're a month early. We would often do that surveillance mammogram a month early or a month late. The key is to try and get regular screening or regular surveillance, because that's when we catch the cancers that recur or are new, growing at different rates. So that's the best time to do the screening. We know that women who have a personal history of breast cancer do have a higher risk of a recurrence or a new breast cancer. The risk, it varies completely depending on the stage at which the cancer is diagnosed and the type of histology grade. Is it ER/PR positive, or is it HER2 positive, or is it triple negative? And also how much the nodes are involved. But typically, we know that women have a recurrence rate of about 1% per year. Okay, again, that's the average. So that means if we have a recurrence or a new cancer, we really want to pick it up, detect it early, because that has the best correlation with outcome. Even if you've had one cancer and you detect another cancer at an early stage, your outcome is much better. And every cancer, new cancer diagnosed, is very dependent on the stage at which it's diagnosed. So that is the most important prognostic sort of feature that we have. We want to detect it early. That's the key.
I think that's very helpful and a great full answer. Kathy, back to you.
Yes, and again, to the same question, what timeline are you discussing right now? Is it the 1 year, post 5 years? Is there a difference in keeping that 12-month surveillance as time goes on without new diagnosis?
Great question, Kathy. So the problem with breast cancer, right, is we could be 20 years out and we could get a new breast cancer. So we want to keep that theory, that principle of early detection of breast cancer. That's our guiding principle. And we know that if somebody is in good health, right, so they have a life expectancy of 7 years or more, okay, and most of us have that, right? Even more than a quarter of women 84 years and older have a life expectancy of 7 years or more. So as long as we're in good health, we should continue to do this annual surveillance mammogram screening up until there's such a time when there are other competing issues, bad heart disease, stroke, then maybe we don't need to. But there's no set age to stop. So it's really up to your health. And the recurrence rates are, as I said, about 1% per year. And we have 20-year studies showing that holds up. So you're never clear. So we all want to keep, that kind of early detection principle as much as we can.
Well, it's sort of like going to a doctor and do a yearly checkup. I mean, why would somebody stop doing that, right? Yeah. So you go for a blood test, you have to go for a colonoscopy, whatever it may be. Great, thank you. So I'm going to go to another question that was submitted to us. Why does supplemental screening end at age 69? Now, this question is unclear to me because which supplemental screening are they referring to? So
it's a good question. And I had to give a talk last week for the Canadian Association of Radiologists, and I was talking specifically about high-risk screening. So I I think that the key thing about supplemental screening is it's screening in addition to an annual mammogram. And then you add in the ultrasound or the MRI, right? Because you have dense breasts. That's the supplemental screening we're talking about. So in the high risk program where we have the most data, most evidence, lots and lots of really good studies, we stop supplemental screening with MRI for women at the highest risk of breast cancer. You know, they have a 1 in 4 chance or more of getting breast cancer. And we stop at age 69 in those women. And the reason is that it's thought that probably most of the high risk cancers have developed before the age of 69. And then it just reverts to the average risk of getting more diagnosis, and that the mammogram is sufficient. So I think that, the average recommendations, and that's also what's adopted by the densebreastinfo.org organization in the US, is that we do annual screening or annual surveillance for women who have the increased risk of breast cancer or a personal history of breast cancer. We keep the supplemental recommendation of supplemental ultrasound or MRI up until age 69 and follow the high risk guidelines. I don't think we have a lot of evidence that really says we have to stop then, but that's where it's come from.
Okay, good. Jen, I'm going to ask you to ask the live question now.
So I'm going to try and synthesize a whole bunch of them. We have a lot coming in around maybe we could break it out a little bit. First of all, what's recommended in terms of surveillance for the average risk person who's had a personal history of breast cancer? What then would be recommended for high risk women? And how do you maybe tell if you fall within that high risk category? Like, how do you know that you're part of that and you should maybe have additional screening? So if you can, there's a lot of questions, sort of people trying to figure out what they should be receiving in terms of that surveillance and what types of modalities should be used.
Okay, I'm going to put in the chat a very good website that gives you a risk calculation of lifetime risk, and anybody could do this. Okay, so it's not going to hold up to your doctor, but it gives you an idea of what your lifetime risk is. So I'll just put that in the chat right now. It's this website is called Iconopedia, and it's basically it is a way of calculating lifetime risk of breast cancer when you have no personal history of breast cancer. Okay, so this is not going to apply to the majority of our audience where there is a personal history of breast cancer. If you have a personal history of breast cancer, your lifetime risk of another breast cancer can be calculated using a different tool called CanRisk or Boadicea. And that is more difficult to use. And that's usually done with genetics counselors to help. But this Iconopedia is a very quick way of estimating your risk. And so I think it's a very useful tool to empower women to say, I am at a high risk. I have, 3 relatives or, a father or a brother or sister with breast cancer, and I have dense breast tissue. And so it's a helpful tool to understand your lifetime risk of breast cancer. So the lifetime risk of breast cancer for an average risk woman at 40 years and older is about 1 in 8 or 12%. High risk is 1 in 4 lifetime risk or 25% lifetime risk. And that would put you into the high risk category. And that high risk category, we will, and this is part of the Canadian Association of Radiology guidelines, recommend annual mammography, okay, starting at age 30 for women at high risk, and annual screening MRI. So this is, and I don't want to make it too complicated, but if you have a personal history of breast cancer and you also have other risk factors, then you also may be high risk. Even though you've had a breast cancer, you might be, high risk of getting another one. that can be assessed by these genetics counselors, and that the referral has to be made, and they will do the calculation of lifetime risk. And if you qualify for a lifetime risk of greater than 25%, then in Ontario, you will be screened with MRI and mammography. It depends on where you live in the country. So there are different criteria. For example, in Newfoundland, you have to have 3 first or second degree relatives with breast cancer. And I'm forgetting all the specifics, but that you have to have a lifetime risk of 25% or greater as well. And it depends where you live. But generally speaking, the principle is that if you have a high lifetime risk of breast cancer of 25% or greater, then you will be eligible for high risk screening with mammography and MRI every year. So I think you had some other questions on that topic, but I wanted to make that clear. So can you go back to the question, Jen? Was there another?
Can I ask one
Go ahead,
question
Kathy.
around that? Yeah, I just have a quick question. So the tool and the link, that's wonderful. I hope people are going to use it, but that's self-advocating basically and doing your own, sort of tool. You're using it yourself. Do the general practitioners know about this tool? And when somebody goes to their GP and says, look, I've done this tool, please refer me, how much of resistance will there be? Or is it something that is going to be, yes, sure, let's get you screened?
I think it's variable, Kathy. There are some people, some family physicians who are very up to date with this, and there are others that are really not. We know this. There's a lack of awareness about how to calculate risk of breast cancer, and part of the mandate of the Canadian Society of Breast Imaging is to try and provide more up-to-date information for family physicians. I think it starts with our patients, and this is a great place to start, but we have to advocate it and try and provide this information to our family physicians. Yeah.
Thank you.
So the other piece of that, I guess, in terms of this, the second part of that question was around like what different modalities should be used. So traditionally, as part of the screening program, women would be receiving a mammogram, but then, and you spoke to some of the MRI in terms of the high risk screening. What is the role of ultrasound in there as well? There were some questions around that being another screening modality, and what role does that play for high risk or non-high risk patients?
Yeah, and I see, a few people, and I hear this a lot, and our oncologists hear this a lot too. My mammogram missed my breast cancer, so I don't trust it, right? And I would never have a mammogram again. So there are several parts to that answer. One is that what happens after you've had a personal history of breast cancer is that oftentimes, not everybody, but the density of the breast can decrease because of tamoxifen or the chemotherapy or the, so it actually becomes sometimes easier for the radiologist to interpret the mammograms, and the density can be lowered. Not everybody. This happens to some, but it's also there've been many studies looking at this, and the type of cancer that you have when you're first diagnosed, it may be a completely different cancer if you have a recurrence or a new breast cancer, and it may show up completely differently on the mammogram. So we know that the sensitivity of the mammogram decreases after a personal history of breast cancer because of some of the changes in the breast, but we do have good studies that show that actually survival for women who've had a personal history of breast cancer with a recurrence is actually better if they have had regular surveillance mammography. So the key, again, is early detection. How do we get that early detection? And that's what we're always aiming for. So we have in our city, we have established these guidelines for women who have a personal history of breast cancer. We do regular mammograms every year, and we add a surveillance or a supplemental screening MRI if they're diagnosed under the age of 50. And then we do that every 2 years. Now, why every 2 years and not every year? Because the evidence suggests that MRI is so sensitive that it picks up the cancers at such an early stage that it can skip a year, and you don't get the what we call the interval cancers, or the cancers in between screenings are zero with MRI screening. So it's probably the best test. Capacity is a huge issue in Canada for MRI. And so we continue supplemental ultrasound after the age of 50, because then we can accommodate that. And we do that every 2 years as well. It's very good. Ultrasound is great, but it's not as good as MR. So, but it's, you have to weigh the resources, available resources, an intravenous injection, and decide and what's available in your city or your community. Did that answer the question, Jen?
I think so, yes. That's,
Okay.
I'd say that covered off on that. Kathy, back to you.
Okay, so we're still on that question in my mind. Why don't oncologists include MRIs for surveillance of women who've had breast cancer? Why is that not a standard of care?
Well, we're trying to work on it. I would say there's a lack of understanding of radiology as a whole by some of our colleagues. And so the best ways that we are accomplishing this increased awareness is more with education, multidisciplinary meetings, trying to understand this and to share this knowledge. And I would say we've come a long way already. So many of our oncologists are aware now of the risk of dense breast tissue. And so I think it's evolving. It's evolving slowly, but it's evolving. So I think we are making headway. And that's why I think it's so important to empower all of us here to be aware of what the issues are. I would say that the oncologists are not doing this, out of they just lack a full understanding of the impact. And again, early detection of breast cancer is feasible with MRI and feasible with ultrasound. And so we need to advocate for that and help do this, to do this. And we also have to do it in a way that we don't have so many abnormalities that we overwhelm our medical system, right? We know that there are false positives. And so people have to be aware, if you do an MRI, it could lead to more biopsies, and it could lead to, more follow-up imaging. And so we have to regulate this in a way that we, are aware of we live in a public healthcare funded system. We don't want to overwhelm the system. So I think that's the evolution that we're seeing. I hope that explains it a little bit.
Yeah, no, it makes sense. And especially when you're discussing universal healthcare in our country, we don't want to, overburden our costs if it's not truly a necessary step to take. However, from a patient point of view, you think, if it's out there, why am I not getting it? So those are the things that go through somebody's mind, especially if they want to keep on top of their, health and make sure that everything is done to them as best possible. Okay, I'm going to ask another question that has been submitted. The question is the recurrence risk different for the various subtypes of breast cancer? I guess that's not a radiologist, but that's more radiologist. Yeah.
Well, and I actually alluded to that at the beginning when we were talking about early detection. The recurrence rates vary depending on the type of tumor. So we know that, triple negative are more likely to recur, and we know HER2 positive are more likely to recur. So we have to be mindful of that when we diagnose cancers. But the most important is really the stage at which it's diagnosed. So that's the recurrence rate is really very much of a fundamental correlate with, that sounds like a long word, but it really correlates well with the stage. So the reason why larger tumors or higher stage are more likely to recur is they have they've had a chance to mutate. There's more different parts of the tumor. So they're harder to treat and they're more likely to recur. So that's the goal of early detection, is to catch it before it's time to mutate or grow or spread to the lymph nodes, which has a higher likelihood of recurring.
So it's not biology of the tumor, right? It's
No,
the size.
Absolutely. Biology is very important, but it's trumped by stage.
It's trumped by stage. Interesting.
Yeah.
Okay. However, there are small tumors that do also lead to lymph nodes,
Yeah,
as well. And some women have small tumors and they still have a lymph node. So is that the chicken or the egg? Like, I mean, it's is it the biology or is it the size, right? I guess it's different. Or
no, absolutely. And one of the limitations we have currently still is that 30% of cancers eventually metastasize. So we, despite all our best efforts, so we have to be aware of that. Like it is a fact. How we prevent it, I mean, that's our, we're all doing that to try and, achieve that, but we don't have all the answers.
Thank you. I think I've pushed too much on this already. Okay, I have another question. Somebody's writing, countries in the European Union are currently in the process of updating imaging screening guidelines based on breast density. For people with very dense breasts, for example, they recommend MRIs. Is anything like this happening in Canada? I think you've kind of answered some of this. Yeah.
Well, I like the question because it's absolutely true. There's the European Society of Breast Imaging guidelines were just released about a month ago, and they recommend screening as cost effective if you screen with mammography alternating with MRI every 2 years. For women with the most dense breast tissue. And this is based on very, very good evidence of over 3,000 women in the Dutch screening program, women at average risk for breast cancer who are being screened in the program every 2 years. And what they did is they invited women who had the most dense breast tissue, okay, category D, to participate in MRI screening. Now, not everybody took them up on that invitation, but the women that did take them up on the invitation to be screened with MRI had almost no interval cancers, which means that cancer that develops in between screens. Whereas there were 5 per 1,000 interval cancers in the non-MRI screened group. So we know that women with dense breast have the highest rate of interval cancers. That means cancers that are detected in between the screens. And the reason why those cancers are bad is that they're more likely to be larger at diagnosis and they've already spread to the lymph nodes. So by adding the MRI, what they did is they reduced that interval cancer rate to 0, almost 0, so 0.5 per 1,000. And so the cancers that were diagnosed with MRI were all early stage 0 and stage 1. They had a few that had lymph node metastases on the first MRI screening, but in the second group, none at all. So they were all detected at an early stage. And these are the biologically active ones. These are the triple negatives, the more likely aggressive high grade tumors. So it's really been argued that MRI is detecting the most important cancers. They're really the ones that are going to cause the harm by spreading to the rest of the body later. So this is the reason for the recommendation to screen with MRI for the women with most dense breast tissue. Now, the Canadian Society of Breast Imaging came out with a report earlier this year suggesting that this should be considered for women with the most dense breast tissue. And it's being, advocated, but I we have not seen any adoption of this kind of standard, and we're not even doing it, you know, where we're quite aggressive with that kind of screening in Ottawa. But I predict this is going to come. And just think, if you did an MRI screening every 3 years, you might not need to do the mammogram, you know, as often, because you would pick up these really important cancers. And they showed in their study that you could potentially just screen with MRI every 3 years, and it would be as effective as a mammogram every 2 years plus the MRI every 3 years. So maybe we don't need the mammogram in everybody if we do
Right, right. Well, that's very interesting. And what do you think would take for this to happen in Canada? Where's the where's the backlog of it? Who's not allowing this yet?
The obstacle is that, well, we have several, but the main one is we don't have enough MRI machines in Canada. We're one of the worst in the developed countries to have the fewest number of MRI machines. So we need more MRI machines. I did hear that there was a commitment by the Ontario government to establish more MRI machines. I think it's becoming recognized as an important aspect. We need more training for our technologists, the people who are doing the MRI machines, and we really need the capacity.
Right.
And the other thing, I would say, sorry to interrupt, Kathy, but the other thing I would say is that we need to shorten the amount of time that women are in the MRI machine. So using these shortened protocols is a way to help us do more MRIs and to do it much more comfortably. So, you know, if I told you it would take 45 minutes to have the MRI, that's a long time, but we can do a shortened protocol now in 12 minutes.
Oh, so is it more cost effective? Instead of doing all these mammograms, would the health system be better off?
Well, that's what they're showing with this cost-effective study in the Netherlands. We haven't done one in Canada, so that would be something to really look at. And I will say, you know, there are some concerns about the intravenous injection. Some people worry about the intravenous injection of gadolinium. There is evidence that it does accumulate in parts of the brain, particularly after many, many years. But there's a type of gadolinium that's better than others to do that. It's called a macrocyclic agent. And we've been using that for 10 years, and we have no evidence that it's harming people. So I have no hesitation in recommending it. We've been doing it, as I say, for 20 years in Ottawa for our high-risk population, and we have no issues whatsoever. But it is an intravenous, so, you know, maybe we'd have to think about that. It's an intravenous injection over a mammogram, but I think that is the future. We're going to be needing contrast for more early detection. Thank you.
I have another question. Are there dietary factors that are associated with dense breast tissue?
So it's interesting. The dietary factors that are associated with dense breast tissue are actually the ones that are associated with increased risk of breast cancer. So there you go. So what are some of the factors? So hormones, hormone replacement therapy, early onset of your period, late onset of menopause, longer time exposed to hormones. Those are associated with higher breast tissue density. What about what we ingest? Well, high sugar diet has been actually correlated with high breast tissue density. Kind of funny, eh? You think that would be more likely to cause fatty breasts, but not in some of the evidence. I don't think there's a lot of strong evidence, but it certainly suggests that. Alcohol is actually something that also increases the breast tissue density. So, and we know alcohol is a real risk factor for breast cancers. Having more than 2 alcoholic drinks a day increases the risk of breast cancer. So being mindful of those dietary influences can really help us to maybe try and keep our density lower. But the density really is determined for the most part by genetics. So identical twins have the same breast tissue density. You know, it runs in families, and But it's just, I think a healthy diet and exercise are all very helpful to minimize the breast tissue density as much as you can and the risk of breast cancer.
Right, right. Great. Jen, I'm going to hand it over to you for live questions.
So there's a couple questions from people who've had a double mastectomy, and what are the recommendations? One person saying she was told that there would be no surveillance done. Another person asking, what is the surveillance that should be done? So for those with a double mastectomy, what should they be receiving in terms of surveillance?
So it depends on if they've been reconstructed. Okay, so if they've had a double mastectomy with no reconstruction, just the breast, the chest wall being flat, then there is no surveillance imaging recommended. The what's recommended is just being aware if there's any changes and most of the recurrences will be felt. They're clinically felt by the patient, the women who experience them. And I believe that some of the oncologists are doing an exam, a clinical breast exam, or an exam when they do in the short-term follow-up. But I don't know that there's a strong recommendation to do that. So it probably will be left to the discretion of the oncologist, but there is no imaging recommended for surveillance for those women. Women who've had a reconstruction with a breast implant, currently, there's no recommendation to do any surveillance imaging because the recurrences occur typically along the surface of the skin. They're pushed out by the implant. Now, there are some new kinds of implants called pre-pectoral implants, where they are in front of the pectoralis muscle, the chest wall muscle. And there's some very little bit of literature in the US that says you should do MR in those cases. We are not doing that. There's very little evidence to suggest that that's needed, and most recurrences should be felt, but it's a little bit contentious. The other kind of reconstruction is if you've had part of the tummy pulled up, a tram flap, or part of the muscles pulled over, called a deep, a muscle, the obturator, the part of the abdominal wall on the side. And this is also somewhat controversial. We're actually just in the process of looking at our data, and we typically do a mammogram on those women, and we do detect cancers. And the reason why we do it is because some of the recurrences are not felt, they're not palpable. So they occur close to the chest wall, and so they can't be felt by a clinical exam or the breast changes. And so again, striving for early detection, we aim to detect them with a mammogram before they're felt. So that's the only indication where we will do mammograms for women who've had bilateral mastectomies, where they've had another term, sorry if I'm using too many long words here, is autologous reconstruction, where it means that part of your own body reconstructed the breast. Does that answer the question?
I think so, and that provides a variety of scenarios, which is really helpful. There was just circling back to the staging question for a minute. So you'd mentioned the stage and the grade being a factor in terms of recurrence. Someone was asking, where can I find my stage information? So is this a radiologist question or something they should be asking their oncologist for? They were only told that they're early stage.
Oh, excellent question. Yes. No, the radiologist would not have that answer because the radiologist is diagnosing it based on the mammogram, and they wouldn't have a sense of what the final pathology was at surgery. So the oncologist will always take that into consideration when determining what kind of treatment to do. So the oncologist will have your stage, and stage would include the tumor size, whether the lymph nodes are involved, and whether there are any metastases. So it's called the TNM, or stage is what we aim for. So I will say that a measure of a good early detection is stage 0 or stage 1. That's when we really want to pick things up. Too many of our women in Canada are being detected at stage 2 and stage 3. and still about 5 to 7% are detected at stage 4. Most of those women at stage 2 or stage 3 or stage 4 have not been undergoing regular screening, or they have dense breast tissue and their mammogram did not detect their cancers. So we're always aiming for early detection at stage 0 or stage 1.
I think that's really helpful. There's another stage question. Sorry, Kathy, and then we'll go back to you. I thought I'd put them all together. So in terms of staging again, someone's asking if it's in the lymph nodes, is that considered stage 3 or stage 4? What stage would that be considered?
Typically stage 2. It depends on how many lymph nodes are involved and whether, how big the lymph nodes are. But typically it would be stage 2. Still very treatable. But, as I said, we are always aiming to try and pick up the cancers before they've spread to the lymph nodes.
Absolutely. So Kathy, we'll go back to your questions.
Okay, so just a small question about the lymph nodes. What are microscopic, I guess, cells in the lymph nodes? Not full-blown lymph nodes with cancer, but just small detections. What's the difference?
So that term is micrometastases.
Okay.
It's a few cells that have gotten into the lymph nodes. So it does, and it depends how many, but it does say that the lymph nodes are involved, but it's a very, very small amount. So it's much better than if you have a lymph node that's, that we can feel that's 3 or 4 centimeters. So it's a good thing because it's much earlier than the full lymph node being involved with the whole tumor. So it's a much lower tumor burden, if you like. Okay, and again, quite treatable.
Okay, great. So the next question is, so this participant shares that she had DCIS in her left breast at age 55 in 2002, had a lumpectomy and radiation in 2019, and at the age of 72, because she had nipple retraction on her left breast and was diagnosed with lobular invasive cancer. This was not detected on any of her mammograms over 17 years or on ultrasounds, but on an MRI, it was a very large tumor. She is not eligible for MRI screening due to her age. However, she can afford private MRI. Is this something that you, Dr. Seeley, would recommend for a patient with her history? And if so, how often should she have an MRI done?
So it's difficult to give advice based on, not knowing the patient and
Right.
not knowing the imaging. But I will say a couple of points that come up that I think are really important. Lobular carcinomas are not about 15% of all breast cancers. They are the ones in the United States that are responsible for the most lawsuits of missed breast cancer because they're very difficult. They tend to grow not by causing a big mass, but they tend to grow along the architecture of the breast tissue. So it can be very subtle and very hard to diagnose. And I personally have missed lobular carcinomas on the mammograms and on an ultrasound and seen it on an MRI, just exactly like this woman said. MRI is the most sensitive to pick up all cancers. It's not 100% though. I will say the sensitivity is about 95%. So it is possible to miss cancers about 5% of the time. It's nothing is perfect, unfortunately, but the combination of all of these really helps us. So again, it goes back to that question of, if your cancer was missed by one test, does that mean it's always going to miss it on the next? And the answer is really, it depends. It depends on the density of the breast. It depends on how things look. It's hard to recommend. I always say start with the annual screening, with the annual mammogram. And then if the density is really high, we may need supplemental screening for that. And if the breast was if the tumor was very large, there is a higher recurrence rate. So it's something to be much more mindful about and to push for extra imaging if need be. So would it be a bad idea if somebody pushed to get a private MRI? I would say no, absolutely do it. I just don't know that it has to be done. And that would really depend on what her imaging and her case scenario would be. So I can't say anything more specific than that. Yeah.
Yeah. Okay, great. I'm sure that clarifies a little something. So my next question is, does a high oncotype score make a difference in type of surveillance that should be done?
So currently it does not. We just know that there's a higher recurrence rate, right, with an higher oncotype score. So we haven't titrated the type of surveillance with that kind of score. There is a lot of research going on in that area, and I expect that more will come in the next few years. But at the present, no, it doesn't change.
Okay, thank you. Jen, do you have any live questions?
Yeah, so a question around whether the location of the first cancer has any bearing on what modalities you may choose to use in ongoing surveillance. So this person writes, for example, a first cancer in a difficult location, would this need a different modality for ongoing surveillance compared to an initial tumor in a more straightforward location?
If it's in the breast, we would recommend the same. It wouldn't change anything. And I think sometimes we might have a challenge because it might be at the edge of the breast tissue, but it really wouldn't change what we recommend, which is wherever there's breast tissue, we want to be imaging, looking again for early detection. It's interesting. Sometimes I hear from women who come through our center saying, oh, my oncologist told me I didn't need any more mammograms. But we really would, if we're actively going to treat, we would continue to screen with mammograms at the very least to start, not rely on CT or MRI. Like that's the standard baseline. And I think that message has to be made very clear to all of our patients that that's what we recommend, regardless of the type of cancer, regardless of the density of the breast, regardless of where it was located. If you have breast tissue, you really are at risk for another cancer. So we want to make sure we keep screening you.
Can I ask a question around that? Basically, it's somewhere just about where are the most typical locations of a tumor in the breast? Outer, top, bottom? I don't hear that many questions around that, but it is a question that's always been, it does make a difference. Like, what are studies showing? Like, can you elaborate a little bit on that?
Absolutely. So the most common location of a breast cancer is in what we call the upper outer quadrant.
Right.
So the part that's going towards the axilla. And it's about 60% of cancers occur there. And I think the reason is that's where we have most of our breast tissue. So it's not for everybody, but I think that's the most common location. But a breast cancer can occur anywhere in the breast. And the breast can go quite high up. We teach our technologists, you got a really high image, high and low inframammary fold, medial, lateral cleavage, and so on. So we have to think of that tissue. And sometimes women can have accessory breast tissue in the armpit, right? So that can also be a place to get a primary breast cancer, not just lymph node swelling. The blind spots for radiologists, okay, I'm giving you a little clue here. So the blind spots for the radiologists happen to be behind the nipple and close to the chest wall. So those are the areas that I'm always teaching my residents to try and look there. The reason why around the nipple is so important is because there's a big lymphovascular plexus. So all of the lymph node, the lymphatics start and they converge on the nipple. and then they spread to the lymph nodes. So if you have a cancer that's involving the nipple, it's more likely to spread to the lymph nodes. So we really want to pick up those cancers that are close to the nipple. So paying attention to a bloody or a watery nipple discharge, or a new nipple inversion, or changes in the skin around the nipple is really important. So if you have that kind of symptom, you want to tell your technologist, because that would alert the radiologist to remember to look in the blind spot.
And does it make a difference in the diagnosis and the prognosis where the location of the tumor is? Is there such a thing?
I don't think so, Kathy. It's a good question. It's really, again, dependent on the size. So, and the tumor histology. So yeah, we'll keep with those three things, whether they've spread to the nodes, the tumor size, and the tumor biology.
Okay. Next question. The person writes, I was diagnosed with stage 4 breast cancer, and I'm wondering what imaging should be done.
Diagnosed with stage 4 breast cancer?
Yes.
Okay. So the key with stage 4 is managing the parts of the body that are affected. So typically when we diagnose stage 4, it's spread to the other parts of the body. So it could have spread to the brain, it could have spread to the bones, it could have spread to the liver or the lungs, are the most common locations. So the oncologist will order the CAT scans for those parts of the body, and typically for the brain, an MRI of the brain to see and monitor. And we have much better treatments now for metastatic cancer that can help monitor, and then we can monitor how they respond. And I've seen miraculous responses with some of the chemotherapy agents. So depending on where it's spread to, and depending on whether you have symptoms, that's when they'll typically do, it's usually a CAT scan and then MRI of the brain, typically. For if all of the metastatic disease is kind of treated, then you would probably want to continue with your surveillance mammogram to make sure that it's not coming back in the breast, because that would be very treatable, right?
Right. Good. I'll go on to my next question. What is the role of a blood test using in conjunction with the mammogram to detect recurrence?
So right now, there is a lot of research being done on blood tests to look for biomarkers and to look at whether they help to identify early stage breast cancer. No blood test right now is available that is accurate and proven, as well as we've proven with mammography, which is, as I've said, not perfect. It's very exciting to be part of these blood studies. And I will say that the TMIS trial, which unfortunately is not available to women who've had a personal history of breast cancer, but it's available to women who are, looking to be screened either with that tomosynthesis or not. That's part of the trial. We're looking to see if there are blood tests that help predict breast cancer. And so we don't have anything available yet. I would be cautious about using a blood test that you have to pay a lot of money for when it's not been well proven. Right now, the only test that really we have, the best test that's proven, is mammography with the added supplemental screening that I've already described. So I think it's time now to be part of research studies and to find out what's going to work. That's really what we want to do. So I wish I could have better news to say it's really available, but at the present it's not.
Oh, that's interesting, because I've not heard of one myself. And I'm just thinking what kind of blood test, what would they be looking for? A protein and like?
Yeah, proteins and something circulating in the blood that might tell us that, we have that kind of blood test for some other cancers,
Right,
like
that's right.
testicular cancer. And when you have ovarian cancer at a certain level, it goes up. But we have nothing that is really, at least to date, been shown to be effective for early detection of breast cancer. Maybe
Right.
it's going to be later stage. So we want that. Again, I'm always aiming for early detection. That's my job.
Right. Yes, that's true. And most of the blood tests that are, searching for, those are used mostly as you're treating patients, like CA-125 for ovarian cancer. That goes along with to see if you're improving with the treatment or not, I guess.
Exactly. Yeah.
So we're not there yet, I guess, for detection or for early detection. So I have another question. Is there a chance that a mammogram could spread cancer cells to the lymph nodes?
I'm so glad that person asked that question, because it's so interesting. There are a lot of myths about mammography, and a lot of myths about screening. And again, it's based on not full knowledge, and also it's based on some old studies. So the old Canadian National Breast Cancer Screening Trials were done 40 years ago, and they called it a screening study, but they actually took women who were volunteers, who many of them had lumps already. So they were symptomatic of cancer, and many women already had their cancers had spread to the lymph nodes. And what they found is that more women with the spread to the lymph nodes were recruited into the Canadian screening part of the arm of the trial. And so there were more deaths, unfortunately, in the screening arm. Could you believe it, right? So
Wow.
There were actually 1.36 times more deaths in the screening arm than in the non-screening arm. And what they initially said is that the mammogram was causing the women to die.
Because Who's they? Who's they? Who said that? Who's they?
To spread, the actually lead investigators. The lead investigators said this. They subsequently retracted that, but it's still a perception that maybe doing the mammogram actually squeezes the cancer and spreads it to other parts of the body. So there is absolutely no evidence of that. In fact, we have 8 randomized controlled trials. The only 2 that didn't show a benefit were these Canadian trials, which unfortunately is the case. But the 6 others showed that doing screening mammograms reduce the mortality of breast cancer by 40%. Invited to screen was 20%, and if they actually participated, 40%. So it's I want to be credible and accurate here. There is a benefit. So it doesn't actually spread it to the lymph nodes, and so the risk is very minimal. There are risks of doing a mammogram. You might be more likely to have a false positive, or to lead to a biopsy that might be benign, but it's not going to cause harm by spreading the cancer anywhere, or it's not going to cause harm by actually causing a cancer from the radiation. That's another question that comes up.
It does.
That's a risk. The risk has been calculated to be more that like 1 in 300 to 400,000 of that risk. So it's a very, very minimal risk.
But once you have surveillance, or even if let's pick surveillance, your tumor is already gone, right? Because you've had your surgery, your treatments. So there is no cancer. Technically, there is no cancer there. So having a mammogram, what is there to provoke it going to lymph nodes? Like I don't understand the question, actually.
I think the fear is that when you have a lump, it's more like you go in for and you do a mammogram and you're worried it could spread, and that really is not the case. So I don't think there's any question that's not good to be answered. So.
Oh, no, the question is good,
Yeah.
but I'm trying to understand it in my head. How would that work? Of course. Yeah, it's a great question. My next question is it recommended to radiologists in the Canadian Association of Radiologists guidelines that density be included in diagnostic mammogram reports? Sorry, it's not written. Am I reading it right? Be included in diagnostic mammogram reports.
Yeah. So I'm going to revisit what I said, I think the last session, and again for here, just for everybody to just be on the same, so we know we're talking the same language. So a screening mammogram is done for when somebody doesn't have symptoms, right? There's no lump, there's no changes of the skin, nothing. So it's no symptoms of cancer. A diagnostic mammogram is done when there are symptoms of breast cancer. So, you either present because you have a lump, or you have a nipple change, or you've had an abnormal screening mammogram and you get called back for extra images to find out what it is. Those are diagnostic mammograms. So the Canadian Association of Radiologists guidelines states that we should have the breast tissue density reported on all mammograms. So it should be reported on a screening mammogram, and it should also be reported on a diagnostic mammogram. And there's been a lot of work across the country to try and standardize that. In screening programs, they're now reporting density and according to the 4 categories. And if the density is not reported, that should really be raised as a question to your family physician or your oncologist. It's supposed to be there. Why isn't it there? So it's a good feedback loop to say we expect this on all of our reports.
That's good. I have a quick question about you using the word diagnostic for women who've had breast cancer already and being surveillanced, right?
Yeah.
From what I see, the hospital I work with, an oncologist will write diagnostic. They won't write surveillance. So I don't want participants listening in to get a little bit confused, because diagnostic, from what I understand, is just to make sure that this patient has had breast cancer. And so they have diagnostic and they have screening. Is it the same throughout the country? Is it different province to province? We're bringing in a new word now.
Okay, we've learned a few words here. That's good. Yeah, it's absolutely the case. And in the US as well, they use the term diagnostic mammograms for any surveillance mammogram.
Correct.
So it depends on the province, because in some provinces you can only have screening if you're in the screening program. And if you're in the screening program, you can't have had a personal history of breast cancer. So it varies. I'm sorry, Kathy, we speak many languages, but this is the understanding of a diagnostic mammogram typically is that we're doing it for diagnosis of symptoms or abnormalities, but it also does apply to women who have a personal history of breast cancer.
Okay, good. So we can all think, okay, good. They can be used in many ways.
Totally.
I'm going to go on to the next question. Can having a core biopsy of a lymph node spread cancer cells faster somewhere else?
Oh, yeah, that was a question. Well, I often get asked this from my patients is there a risk of spreading the cancer cells by doing a biopsy? So there actually have been studies to look at this, and there have been examples where the cancer cells were, there were a couple found in the tissue near the cancer that they thought was related to the biopsy, but the cancer cells did not survive. So it's thought that the risk is very, very minimal, and we don't see evidence of that occurring. Now, there are some cancers where this is a big risk, like it's a rare cancer. It's called mesothelioma. And in the chest, by doing a biopsy, you can actually spread the mesothelioma along the tract. This does not occur with breast, and it does not occur with the lymph nodes either. So doing the biopsy is very low risk, and it is not associated with any spread to the rest of the body, which is great because we do this all the time. And doing the biopsy, I think most of our participants probably have had one, so they probably know it really should be done as painlessly and as comfortably as possible.
Yeah, I would agree with that. What about the surgery removal of a tumor? Is there any disturbance that when you remove that tumor, could any of the leftovers, if there's anything, spread?
No, it's again, again, it's not that type of cancer. It seems to be very closely, like the cells are connected to each other. So no, it's not. That's different. Like, for example, ovarian cancer, we worry
Yeah.
about that, but it's not the case with breast. And usually if there are what we call positive margins at surgery, it's because it was bigger than was predicted by the surgeon, not because of the surgery doing anything to cause harm to it.
Okay, great. Jen, I'm going to hand it over to you. Do you have live questions?
Yeah, so a question about whether or not there's any documentation or some type of supporting document available to help patients advocate for themselves to obtain an MRI or other types of surveillance, or even actually in terms of the high risk sort of previvors, if you will, any types of diagnostic testing. So is there any that you're aware of? I know I'm really thrilled to announce that we will be launching an advocacy guide that specifically Dr. Jean Seeley has been kind enough to edit and review for us. So that will be launched in the next week or so. And that actually speaks to, I know you reference a lot of different sources in that in terms of what's recommended and sort of backing up a lot of that information. Is there anywhere else that you could recommend that patients might want to visit to be able to self-advocate?
So I think that one of our patient advocacy groups for Dense Breast Canada is Dense Breast Canada, and they have created an amazing website called mybreastscreening.ca. And what's good about it is it gives you a lot of tools for, depending on where you live, which province you are, or territory, what to advocate for, what's available in your province. And so I think that's an excellent resource. I'm amazed by the amount of work that went in there, and it's very well cited and with very credible information. Every provincial screening program and every province has different, available resources. It's the Canadian reality of healthcare. And I'm aware that the Canadian Society of Breast Imaging is also a very good website. It has some educational tools. It's mainly for healthcare providers at present, but we're going to be establishing a portal for patients to help advocate. And I will say that the Canadian Society of Breast Imaging is going to be having a conference in May. And from that conference, we'll be determining a conference specifically for patients to give some more vital information that I think people would want to know. I'll put it in the chat for the mybreastscreening.ca. Do you want me to put the CSBI one as well?
CSBI one would be great, or I can look that up as well.
Okay, it's very easy, csbi.ca. And what else? There's not enough. There's the Canadian Association of Radiologists guidelines, but those are really for radiologists. I think we need to improve awareness for our patients. I'm so grateful to you to have the opportunity to do this, and I hope that this really helps improve the conversation and information. I'm trying to think if there's anything else. Is there any other websites that you would like that might help?
Those, I think I've just noted the Canadian Association of Radiologists, but I think those are sort of three really great references that you've provided in terms of where patients can go to find additional supporting documentation as well.
Oh, I think I didn't put it in for all attendees, so I'll do that.
Oh, wait, maybe I can copy and paste that. Okay. I've done the same thing.
Okay, good. Thank you.
And then Kathy, I think you had another question.
Yeah. What would you say, Dr. Seeley, is the minimal surveillance that should be done for patients as follow-up care?
The minimum surveillance as follow-up care?
The minimal surveillance. Yeah. What would be the minimal? She writes, what would be the minimal surveillance that should be done for patients as follow-up care?
Yeah. I think, again, the principle is that any woman is at risk for breast cancer. The risk keeps increasing with age. And any woman who's had a personal history of breast cancer is at risk for a recurrence as well. So the minimum if you want this goal of early detection is to start at minimum with a base a mammogram every year. That's that's what we recommend for all of our patients, you know, and it is a decision that everyone has to make. The risks are really quite minimal. The risk is that you get, you know, recalled for additional tests, or you might have a benign biopsy, but most women, when I explain that to them, are willing to, you know, they want to have that opportunity because it really does improve survival. So that would be my basic one recommendation.
Can I ask a quick question around the pickup of, non-cancers, like, false positives? What's the percentage of that now? Because women are going for mammograms much more than they used to with all the programs that are in various provinces, right? And often I'll hear, oh, I've been recalled because they have to, do an ultrasound. And most of the time, most 99 point, they're not. They're just making sure they're ruling out. So what's that percentage look like?
Yeah, great question. So it's about 10% on average. I would say across Canada, we know that in screening programs, it's about 7 to 8%. Okay, so it should be less than 10% for sure. If you get recalled because you have an abnormal screening, whether you have a personal history of breast cancer or not, the likelihood is that it's going to be due to overlapping tissue or a benign finding, okay? About 2% of those will need to have a biopsy, okay? Because there's something like a mass that we can't call definitely benign. So what do you think the likelihood if you have a biopsy of it being cancer?
I don't, percentage-wise?
Yeah.
Numbers are not my forte, but low.
Yeah, it's about if you said to 10 women that you need a biopsy, 3 of them would have cancer and 7 of them would not have cancer.
So it's okay.
So it is low. And I think that's the thing to remember, is that just because a biopsy is needed doesn't mean it's going to be cancer. What we do when we look at the imaging is we grade it according to the likelihood of it being cancer, according to what we call the BI-RADS. So the BI-RADS says if it's 4A, it's the lowest likelihood of cancer, about 2 to 10%. If it's BI-RADS 5, so it goes 4A, 4B, 4C, and 5. And if it's a BI-RADS 5, it means it's a 95% chance likelihood of cancer. So it's more like 9 out of 10 of those biopsies would be cancer.
Oh, okay.
Yeah. So it varies according to how it looks. And radiologists are very good at assessing what the mass looks like, or the calcifications look like on the mammogram or the ultrasound, to determine whether it's going to be a cancer or not. But they're not 100%. And that's why we need the biopsy.
But I think what happens for the most part is that they go to ultrasound next and then biopsy, correct?
Yes, not every abnormality on the mammogram goes to ultrasound. So typically, if it's a mass, we will always do the ultrasound to look and characterize it better with ultrasound. So we always want the mammogram and the ultrasound to try and be done on the same day, so that we report them together and say, yes, I think this is fine, or no, this needs a biopsy, and then determine based on the imaging whether it's an ultrasound biopsy or a mammogram biopsy, okay? But if you have calcifications on the mammogram, you may not go to ultrasound, because ultrasound is not good at detecting calcifications. So we would typically do a biopsy based on the mammogram and what the calcifications look like.
Okay, good. So I'm going to hand it over to Jen. I think she has one more comment to make, or we are out of our time. And this went so fast. I really want to thank you for all this great information, Dr. Seeley. This was fantastic. Jen, I'm going to hand it over to you to do the wrap up.
Agreed. Yeah, and I did. So I put those links in the chat. And just to note that mybreastscreening.ca is working in collaboration with Dense Breast Canada to advocate around better screening and surveillance. And so they would encourage women to also reach out to them directly. So I've put the CSBI and mybreastscreening.ca links in the chat as well. And to Kathy's point, thank you so much, Dr. Seeley. I can't believe the hour and a half is gone. Thank you for joining us again for this session today. and Kathy for hosting it. As always, it's always great to hear the discussion, and I'm always amazed at how quickly it goes. I'd like to extend a thank you to our sponsors again for this session. So Beatrice, Novartis, Roche, AstraZeneca, and Pfizer Oncology. We will be sharing a short survey back with all participants, as well as the link to the recording within the next couple of days. So check your email for that. And thank you everyone for joining us and for your great questions and for an excellent discussion. Thank you so much, Dr. Seeley and Kathy.
Thank you.
Good night.
Good night.
Good night.
Have a great night.
Thanks, you too. Bye-bye.